Welcome to Chapter 21, Head and Face Injuries. You're back with Kent.
And I'm Ryan.
Hi, my name is Yelmer Sherman. I'm one of the new paramedics here in the Yukon. Just moved to Haines Junction, and I'm excited to call that place home right now.
Awesome. Great to meet you, Yelmer.
Welcome on board.
All right, here's a quick look at the anatomy of the head and neck. So the big part here is that the scalp layer is very vasculature. You've got the skull under that, the three meninges layer, which we're going to go in a little more detail later, and your brain and your neck and brainstem. If you want more information, Leslie's got an amazing presentation on all the anatomy of the head.
The skull. Key takeaway point, once again, is there 28 bones that comprise the human skull.
So like I said, we're going to go over the three meninges layers. The basic ones are the dura mater, the arachnoid mater, and the pia mater. And there's blood vessels in different parts of that, and they can capture different amounts of blood. So it's going to affect your signs and symptoms, but it's not something you're going to pick up in the field.
Cranial vaults, 80% is brain, 12% is cerebral blood, 8% is cerebral spinal fluid. The important thing to take away from the brain is that it metabolizes 25% of your body's glucose. This is why when anyone has an altered LOC, one of the key things we check is the blood glucose.
So here you see the different areas of the brain, the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. And the big thing here is that when you start to have head injuries, you start to have strokes, depending on where it's affecting, you'll get different symptoms. So you can see here in the frontal lobe, for example, you've got conscious thought and speech. So if that is injured in any way, you're going to start to see effects there. Same with the temporal lobe. It's hearing and reading, so that's where you're going to start to see problems. It's not something you're going to diagnose in the field.
No. Brain stem. Basically, it's the connection from your body through to the brain. It's comprised of the midbrain, the pons, and the medulla. Once again, Leslie does an amazing presentation on this. Feel free to view it at will.
The big thing to know here is that if there starts to be damage to this, it's going to be a systemic problem because you're going to start to have problems with your autonomic functions, which includes like your heart rate and your blood pressure and stuff like that. So this is going to be a big deal, and you're going to notice this.
Yes. All right, head injuries. There's approximately 50,000 head injuries per year in Canada. 50% of traumatic deaths are from head injuries. Most common are motor vehicle accidents. Some other common causes are fall of the elderly and sports-related incidences.
So an open head injury is going to involve visible dura mater. Your cranial components are going to be showing, or they're going to be penetrated. There's going to be brain tissue that you can see. Apparently, gunshot wounds are the most common mechanism of injury, even in Canada, which kind of surprises me. They do have a high mortality rate. One of the benefits of it, though, is that the pressure gets relieved, which we'll see in the next couple. You don't get that relief.
Okay, closed. It is the most common type of head injury. It's often associated with the blunt trauma. Okay. Brain tissue is not exposed to the environment. However, one of the key things to remember here is that the brain does swell with any type of head injury, and this can subsequently cause an increase in ICP.
Which is where you're going to start to see those deficits that we talked about with the different areas of the brain.
Yes. Now we're going to take a look at scalp lacerations. These always look horrific. However, though, they are typically non-life-threatening in an adult. Children, however, can suffer hypovolemic shock if the laceration is severe enough.
The key thing is they're also easy to control.
Very easy to control.
So direct pressure, unless you see brain matter, obviously don't push on that.
Yep.
But direct pressure, and realize it could get an infection, but there's nothing you can do about that. They're going to get antibiotics at the hospital.
Yes. And treatment is going to be the same basic first aid for all lacerations.
Yep.
All right, skull fractures. There are 4 types, as you can see depicted here in the pictures, and we're going to go through a couple of them. Linear skull fractures account for about 80% of skull fractures. They typically occur along the temporal parietal region, as the picture here depicts, probably because it is the thinnest part of the skull.
It's a suture line, right?
Yeah.
So you have 2 bones that have been fused together, and that's a weak point.
Depressed skull fracture. Okay, this is usually the result of obvious direct trauma to the skull itself. When front and parietal regions are most susceptible, neurological signs are often present. They typically have loss of consciousness on scene.
Basilar skull fractures. These are from diffuse impacts, so falls. They're going to see a lot of very distinctive signs and symptoms, and that's like your raccoon eyes, the blood pooling around the orbit of your eyes. That's where you get to the 2 black eyes. You'll see battle signs, which is a bruise right behind the ear, and you may see cerebral spinal fluid draining out of the ears or nose. And in that case, if you see it's a straw-colored liquid, kind of a corn syrupy, or if it's mixed with blood, you can do a halo test, which is taking a piece of gauze and dipping in there. And if you get the blood and then another zone of kind of a yellowish colored thing, you've got a positive halo test, which means you need to really consider transporting immediately because this is a bad fracture.
Okay, open skull fracture. This one has the highest mortality rate, highest risk of infection, simply because the skull is fractured and the brain is exposed to the environment.
These ones look bad. If they've still got a pulse though, and they still are breathing and they still are conscious, this is transport now injury. If you have exposed brain matter and you don't have a pulse and breathing, this is an injury not compatible with life.
Traumatic brain injuries. All right, is a direct insult to the brain itself. It's put into 2 typical categories. There's your primary, your secondary, and the causes are typically caused by penetration, external forces applied to the skull, your coup contra coup injuries. Those are your whiplash that you will see in a car. Anything that causes cerebral edema or an increase in ICP.
And the primary one, there's no way for us to stop that other than through prevention. So that's us talking to our patients about wearing proper safety gear. It's about going when you go to schools and do those school visits and stuff like that and telling the kids to wear their helmets, wearing their seatbelts. There's not much we can do about primary injury other than prevention. We sometimes can affect secondary injury, but even that, usually it starts from swelling and edema, and we can't stop that.
No. Intracranial pressure. So basically all that is swelling within the brain that compromises the blood vessels in the brain and prevents that important blood and, more importantly, glucose from getting to the brain itself. And this is where people will present with your altered level of consciousness. You will see a slowing of the heart rate and a widening of the person's blood pressure.
It's important for us to recognize this is happening. There's very little that we can do about it at the EMR level.
No.
It's a recognition thing. You can't actually calculate the number of intracranial pressure in the pre-hospital setting. You need to have a lot more stuff than we've got. And the reason it happens, it's helpful to think that it's an enclosed space that doesn't expand. So anything that is added to that area has to put pressure on something else, and the brain's squishy.
Yep. All right, continuing on. These pictures here depict some ominous signs of intracranial pressure as it progresses to the point where it causes actual herniation of the brain, as the brain is pushed through the small opening at the base of the skull. So the first one you're going to see The top one is decerebral posturing, and the bottom one is decorticate posturing.
Once you see this, it's dangerous. The odds of them surviving are low. You need to get them to the nearest care facility.
Yes. All right. Cerebral contusion. It's basically a bruising of the brain. Okay. You're going to see similar signs and symptoms, similar Meninges injuries, 2 concussions. Basically, it's the brain swelling again.
So you're going to start to see intracranial pressure, increased intracranial pressure problems.
And once again, in the field, you're not going to be able to diagnose the difference between a rising ICP or just a cerebral contusion. The key takeaway point is you start to see deficits with any kind of head injury. This triggers automatic transport.
Yeah. So I was talking about how the skull is an enclosed space. So any type of addition in pressure or blood, there has to affect something else inside there. And that's what this is talking about. If you have blood, it's going to squish the brain because the brain is squishy and you're going to have issues.
Intracranial hemorrhage. Key takeaway from this is there is no room in the skull. It is a fixed structure. It does not move or stretch. So something has to give. So when blood begins to accumulate, ICP starts to go up as a result of this. Something has to give, and unfortunately, it's the brain itself. It begins to become compressed.
Because you got to remember, the brain is squishy.
Brain's very squishy. So bleeding can occur anywhere within the brain itself or within those meninge layers that we mentioned earlier on.
All right, the epidural hemorrhage. This is rare in head injuries. This is the one that's going to move fast. So you're going to see this is arterial bleeding. It's going to be, you're going to have a period of unconsciousness with a period of consciousness followed by another period of unconsciousness, most likely. And that's the key there. So if you have a patient who was unconscious and now they're conscious, you still need to have a high index of suspicion and they still need to get checked out at a health center.
All right, your subdural hematomas, okay? It's a rupture in the vein of the bridging between the dura and the cortex. So as soon as you have this rupture, blood is allowed to move up between the 2 ventricles within your brain, and this is typically where you're going to see the raccoon eyes. As blood moves up and forward into the skull, it accumulates in around the eyes, which is what gives you your raccoon eyes, or it settles behind your ears, which will give you the battle signs. The intracerebral hemorrhage, usually as a result of penetrating injuries or rapid deceleration. It typically occurs in the frontal or temporal lobes, and that's usually as a result of front-on impacts or T-bone accidents, as you can see from the injury pattern here. So the key thing to remember here is once symptoms start to occur, these patients deteriorate very rapidly. They have a very high mortality rate. So once again, I can't emphasize this enough. If you have a suspicion of any type of bleed within the head, transport. Do the rest of your assessment en route into the hospital. Time is brain.
Especially in the communities, it's important to remember that even the health center is not definitive treatment. They need to get to surgery, which may be in Whitehorse and it may be somewhere else like Vancouver. So this patient needs the best chance that they can get, which is quick transport.
So the subarachnoid hemorrhage, bleeding into the cerebral spinal fluid as well. This is where Rian mentioned earlier on the halo test. That's when you, as Rian described, you put some gauze into the fluid and it will come out and it will literally look like a target for the hunters in the group out here. So ICP causes the increase, once again, altering your level of consciousness. Your pupils will change. Patients typically will present with seizure. The posturing that we described is a later sign, vomiting, and unfortunately, the end result would be death left untreated.
All right, we're going to move on to the face now. So we've covered head injuries, and now we're going to move on to the face. There's a bunch of bones in the face. The big one that we're going to talk about is the mandible and the zygomatic bone. Leslie has an amazing anatomy and physiology lecture on this one, and I would highly recommend looking at it. I'm going to have it linked at the end of the video.
Your blood supply to your face is primarily through your carotid artery, which breaks off into, as you can see here, your temporal, your mandibular, and your maxillary arteries.
Soft tissue injuries to the face. The mechanism of injury is going to predict what type of injuries you see on the face.
So always be alert to airway compromise. Watch for underlying more severe injuries. If they've injured the soft tissue of the face, chances are the structures underneath are injured as well.
The big thing here is we're going to harp on airway a lot because if there's a problem with the face, your airway takes up most of the back of that. And if it's blocked, then you're going to have, that's one of the three main things that we're worried about: airway, breathing, and circulation. And these injuries can cause issues with those. Maxillofacial injuries. So the facial bones are going to absorb the energy of the impact, and you're going to start to see a lot of bruising. You're going to see lacerations, swelling. The big part here is that you may start to see dental issues, and if you have problems with teeth getting knocked out, those can block airway. Like I said, we're going to harp on airway a lot. If you have teeth missing, consider that there might be an airway issue. If the eyes are affected, you definitely want to cover both eyes, not just one, to make sure that they don't have any sympathetic movement.
Fractures of the zygomatic or the cheekbones. Okay, they're usually always the result of blunt trauma, secondary to motor vehicles or assaults. The patient's face will appear flattened. They will have loss of sensation to their cheeks. Fracture of the nose is not uncommon, and swelling of the upper lip.
The loss of the upward gaze is because the ligaments and muscles are attached to those bones, and if the bones aren't supporting them, then they can't stay up.
Maxillary fractures, okay? They are broken down into three types. They are called Lefort. So, as you can see here, there's a type 1, type 2, and type 3. The most severe case is number 3 here. As you can see, it causes a fracture right through the eye sockets and actually causes a separation of the facial bones from the skull itself.
We don't expect you to remember all of these or be able to diagnose them in the field. This is something just for you to be aware of and realize that it could be very bad for your patient. If you have a suspicion of this kind of fracture, it's going to be very difficult, if not impossible, to bag the patient if you need to do a BVM.
These are patients we typically saw before the invention of airbags, as people would move forward and their face would strike the steering wheel.
Yeah.
Once again, structures of the eye, Leslie does a much better job of explaining it than I do. So feel free to look at the video with the link at the end.
Eye injuries are pretty common. So 100,000 eye injuries occur annually in Canada. They're caused a lot of times by different types of trauma, either blunt or penetrating, and they can be burns as well. One of the big things here that we're worried about is if there's something stuck in an eye and if the vision is impaired. So we're always asking people if they're having blurry vision or if they have double vision, if they can't control their eyes. These are things that are going to cause us to transport quickly. Again, they need surgical treatment, and we can't give that to them in the communities, and sometimes not even in Whitehorse.
Lacerations form bodies and impale the object. So the key takeaway point from this is anything in the eye, we want to minimize the movement of the eyes because eyes will move in unison with one another. So this is why when we cover the injured eye, we also cover the uninjured eye. You want to explain to the patient why you're doing this, because it can be quite a terrifying experience as someone who has suffered an eye injury.
The one of the key things you may have heard life or limb injury. This is a limb injury. So it's considered an emergency when there's a risk to vision, because vision is so important to the way we live our lives. You want to transport these people and give them the best chance they have, which is why we kind of go over this a lot. Lacerations to the eyelids. So this needs basically plastic surgery. And the odds of them getting it here are low. They're probably going to have to go down to Vancouver. And this is going to be a long, tedious process for them, unfortunately. If you do see one of these, you need to make sure you recognize it and transport. Lacerations to the globes are equally dangerous. I actually don't know how they fix those. Do you, Kent?
I have never seen a repaired globe.
Yeah.
I've seen typically when the eye is injured, they lose the eye if it's severe enough.
Yeah. So, transport.
Okay, blunt eye injuries. As you can see here, you will get a variety of signs and symptoms. So the worst thing we are worried about here is the orbit blowout fracture. And that's simply where the eyeball is simply hit with enough force that the orbit itself is fractured and the eye is no longer held by any of its ligaments, and it is free floating and has the ability, unfortunately, to fall out.
Have you ever seen the hyphema? I never have.
Never.
It looks cool.
From a medical standpoint, yes, I could see how that looks. From a patient standpoint, probably not cool.
Probably not.
Probably quite a terrifying thing.
Still be interesting to see one time in my career.
Eye burns. Terrifying. The thing to remember about burns, especially to the eyes, is you want to find out what the burn was caused by. If it was an alkali, if it was an acid solution, you want to make sure that whatever was introduced into the eye does not react with water, because one of the key things we tell you to do is flush the eye with water, sterile water. So keep that in mind before you start flushing the eye out. Thermal burns, this can be welder's flash. I suffered that when I was younger. It's very similar to any person who's ever experienced snow blindness. It is a burning, searing pain that does not go away quickly. And then unfortunately, your infrared rays, these are now laser pointers that are out in the market now.
Some of them are so bad that they get confiscated at customs.
Yep. I have a laser pointer that will range out to about 5 miles.
Yeah.
Wow.
Yeah.
With the chemical burns, it's also good if you are called out to an industrial site to ask for the safety data sheets, the YEMS papers, to see what the plan of care is.
Perfect. All right. Nose. Speaking as someone who's fractured their nose on more than one occasion, it hurts, it bleeds uncontrollably at times. The key thing to remember is blood will drain down into your airway, okay? And you will swallow blood, which, when introduced into the stomach, your body does not like, and you will throw up. Once again, potential airway injury. So, nasal fractures with bleeding, you want to get the person to lean ahead. Make sure you minimize the amount of blood that is introduced into the stomach or into the airway itself. Treatment is basic first aid at this point in time.
The ear. Another one of great videos that Leslie made. His anatomy and physiology videos truly are astounding, and I highly encourage you to take the time to watch them.
All right, key thing about ear injuries externally, we're really not going to do much. There is not a rich blood supply to the ear itself. It's mostly cartilage. They will typically take parts of cartilage from your ear to do facial surgery and reconstructive surgery. The inner ear, we are once again not going to do much with it in the field. They are very fine bones, and you need a person who specializes in this particular type of repair to be looking at it. And you can see by the small structures there, this is why you don't put Q-tips in your ear, because it's quite easy to push them too far and damage the fine structures.
One of the things you're going to see is possibly sensory impairment. So not just difficulty hearing, but difficulty walking. People can get a lot of balance issues if they have an ear injury. So you may not be able to walk these patients out of their environment. You might have to find a way to move them.
The mouth itself. Okay, this is where digestion begins. You chew up the food, it mixes with your secretions in your mouth and facilitates the movement down into your stomach. Okay, your mouth allows you to speak, swallow, and chew. Interesting fact, the hyoid bone is the only bone in your body that is not attached to another physical structure. It is a free-floating structure.
I think we're actually going to go over the hyoid bone a little bit later.
We are. Okay, however, mouth, greatest cause of airway obstruction.
Mandibular fractures and dislocations. These are very common. You're going to see them from any blunt force trauma to the lower third of the face. And you're going to notice a lot of times they're going to be pretty obvious because the jaw is actually going to be at a weird angle. It might be loose. And there is nothing we are going to be able to fix in the field. We need to splint it and we need to transport.
32 pair of teeth. Once again, Leslie never knew it. 20 plus years, never knew there were 32 teeth in the human head. So I give props to Leslie for his presentation.
The big thing here is that when you're documenting, try and document which teeth has been damaged, and realize that if you can't find the tooth, then it may be in their airway or they may have swallowed it. Swallowing it, not so bad. Airway, yes, bad. Transport these people if you can.
Dental injuries. Once again, not much we are going to do for it in the field. You simply try to gather up the teeth if they are visible on scene. You can put them in a sterile bag. They always said put them in milk. I've never known an ambulance service that carried milk on board. It's one of those things they could probably do at the nursing station, however. And as Ryan has stated multiple times, if you can't find them, always make the assumption that they might have gone into the airway or been swallowed.
I found assessing teeth difficult in the beginning, especially. I don't know which of their teeth are normally missing.
No.
And sometimes the break is so clean that you don't really see anything. There's just blood all over the mouth. So what I have learned to do is I tell the patient, run your tongue over your teeth and tell me if there's any change. Because they know what their mouth normally feels like, and if you've ever lost a tooth, you know instantly that it's not there.
Yeah. Key thing to remember now is a lot of people are using meth. One of the key things it causes is dental degrading. They literally, teeth just rot right out of their head.
Which makes them more fragile.
Makes them much more fragile. Moving on down to the neck. Okay, these two pictures depict the major arteries that feed the neck itself and then up into the skull. Feel free to look at them at your leisure. We do not expect you to know the names of all these. Just realize that any type of penetrating trauma to the neck can have the potential to compromise either one of these arteries or veins.
The one that we do expect you to know is the carotid, and that's where we're getting a central pulse pressure.
Once again, the hyoid bone, not part of the skull. It supports the tongue. And no matter what Hollywood said, a person cannot swallow their tongue.
They can't swallow their tongue, but if that does get broken for any reason, the tongue loses some of its ability to stay upright, and so you can still get an airway.
It will fall back into the airway.
So You want to be careful of the larynx and trachea because that's where you breathe. There's also the major blood vessels that bring blood to the brain. So if any of those are cut, the chance of survival decreases quite a bit. The spinal cord's in the back, so that's why we really talk a lot about possible C-spine injury. It's something that we prepare for and we treat cautiously. The muscles and nerves, not something that we normally talk about too much. I mean, it can get injured. We can't treat it. We worry about bleeding. We worry about C-spine injuries. Those are the big things for us.
Yep. If there's been enough force delivered to the neck to cause injury to the blood vessels or to the structures itself, chances are that energy has been transferred through to the spinal column as well. All right, here's some pictures depicting some very graphic injuries. As you can see here from the bottom one, very big chance of airway compromise as well as laceration to the carotid artery underneath. Once again, basic first aid rules are going to apply. We're going to stabilize that looks like it's knife in place and transport. That is the key thing. We're not doing anything for this person in the field. We're going to cover it and we're going to initiate rapid transport.
And we're going to leave the head and neck in position found as much as possible. We don't want to rotate that at all and cause more damage as it moves around. Injuries to the anterior part of the neck. This is your larynx, trachea, and esophagus. So if any of these get opened up to the air, you're going to have a life-threatening injury. These people need to be transported. You need to be prepared to provide airway support and breathing support, and know that a lot of that stuff bleeds a lot. For example, the thyroid is there and it bleeds like crazy.
Yep. At this time, feel free to look through your YEMS protocols.
There isn't a lot of specific instructions for trauma to the face or head in the EMR protocols. The key is it's trauma, and we treat trauma in a very specific way. We control bleeding. We watch for airway problems, we watch for breathing problems, and we watch for circulation problems, and we do it in that order. And ITLS is the main program that we follow with Yukon EMS, and that's what your protocols are based on.
All right, so let's start breaking it down now. So you're probably getting sick of this, but we're going to keep on doing it. So your initial scene assessment. You're going to come in, you're going to assess for safety as you approach before you even get to the patient. Make sure everything's safe before you enter that environment. You're going to determine the number of patients, the location, what type of PPE you're going to need. If you can determine it through the windshield, try to determine what happened. Okay? Also determine if you're going to need additional resources such as the police or fire.
The mechanism of injury you're going to find out from the patient usually. Sometimes you can find it out just by looking at the scene. It's going to help you have an idea of what's happening. It's going to help you decide whether or not you're going to transport this patient right away or you're going to stay on scene and do a more thorough assessment. So this is why we really talk about mechanism of injury and trying to figure it out often.
So your primary assessment. So this is your rapid first look at the patient, your general impression. Okay, you're going to assess the mental status. As we've said numerous times, your brain consumes 25% of your circulating glucose. So if there's damage to the brain or it's starved of oxygen or blood, it's going to manifest as altered mental status. While we're doing that, we're going to remember to maintain spinal motion restriction until ruled out. We're going to assess the airway. If there is an airway involvement or it's compromised, we're going to assist ventilations and with the possibility of inserting an OPA. If breathing is compromised, we can assist with nasal prongs, with O2 by mask, or worst case scenario, assisted ventilations with a BVM. If there is a circulatory problem, we're going to attempt to control all major bleeds on scene. and we're going to assess for any type of disability. We're going to examine, we're going to do a rapid assessment from the top of the head down to the toes. And we're going to determine if there's any injuries that are life-threatening and put them in the correct priority. All right, now we're going to take a quick break and we're going to practice our primary assessment with obvious trauma to the head and face.
For the secondary assessment, you may do this on scene. You may do this en route. This one starts again at the head and moves down. It's just more detailed. You're going to be looking for decap BTLS ticks. You're going to be looking for obvious trauma. And any of the little things that we've talked about, the raccoon eyes, the battle signs, unequal pupils. You're going to take a good listen to their lungs. This is where you're going to do a halo test. You're not going to do this in your primary assessment. You're going to do it in your secondary assessment. And if you're doing a halo test, your secondary assessment should be en route unless you're having an extended extrication. Part of your assessment is going to be a sample history and an assessment of injuries. So we talk about sample quite a bit. It's your signs and symptoms of the injury. In this case, any allergies, any medications that they take, any past medical history, especially pertinent past medical history. When's the last time they had anything to eat, especially if there's a possibility that they're going to go to surgery. And then what happened to cause this. OPQRST it works for so many things. We generally learn it for cardiac, but it really does work for almost every type of illness or injury. When did it happen? What were you doing? Where were you? Provocation. Does anything make it better or worse? Quality. What does it feel like in your own words? Radiation or referred. So does the pain or feeling go anywhere? Or is it located in one specific spot? Or do you have an odd feeling somewhere else, like the left shoulder or something like that? And then how bad is it on a scale of 0 to 10? And remember that is subjective. It's not an objective measurement. It allows you to get a trend for any interventions that you do if it's making it better or worse.
Once again, we're going to take a quick break here. We're going to work on our secondary assessment, including our sample history and, if pertinent, OPQRST. Ongoing assessments. We've made the decision to transport the person into the hospital. So en route, we are going to go back and we are going to reassess. We're going to assess and reassess until we get the person into the hospital. Okay? This includes changes in the person's condition. This may be positive, this may be negative. This is all important information to pass along to the nurse. We're also going to continuously monitor vital signs en route into the hospital. Once again, we are looking for that trend. We're looking to see if his vital signs are improving or they're decreasing. That will directly impact the treatment that they receive at the nursing station, and it may even save the person's life. And that concludes
Chapter 21.
Chapter 21.
Thanks for joining us. We're going to have links to the in-depth lectures from Leslie up on the screen right now, and we'll also have links in the description below. If you have any questions, you can give Clinical Education a call or email us, and we'll see you next time.
Tell us what you liked, tell us what you didn't like. We'll make changes.